and readiness to change in regards to alcohol use disorders, the WELL program. So WELL stands for Wellness Through Empowerment, Living, and Learning. I do not have any relationships to disclose for this presentation. And just to give a general opening statement, this presentation discusses some of the results from an evidence-based intervention designed for those persons living with HIV/AIDS and an alcohol use disorder. So just to give some national statistics that we all may know about HIV, this infographic is part of the infographic that the CDC HIV Surveillance Report 2017 edition. And what I want to point out on this graph is that 52% of HIV diagnoses in 2017 were in the South. Now, to be more specific to Louisiana, where I am, I pulled some of the statistics from those same HIV surveillance reports from 2011 to 2017, just to show that Baton Rouge and New Orleans has been, unfortunately, in the top 5 for a while now. You see in 2014, 2015, 2016, we were actually in the top 3. But 2017, Baton Rouge was ranked number 5, and New Orleans was ranked 4th. Now, alcohol use disorders, or AUD, can be simply defined by the National Institute on Alcohol Use and Alcoholism as uncontrolled and problematic drinking. This is important for our population because people infected with HIV are nearly twice as likely to use alcohol than those in the general population. Also, people living with HIV have 2 to 3-fold higher prevalence of alcohol use disorders, and approximately 8 to 12% of people living with HIV are classified as heavy drinkers. Some of the potential consequences of AUD is that it can just cause people to forget to take their medication or just choose to take it less. As you know, the medication reduces the viral load, but if somebody does have AUD, they're more likely to engage in other risky behaviors, such as unsafe sex or increased use of their drug of choice. Now, if that drug involves a needle, they may be less likely to, make sure the needle is clean. Because of these risky behaviors, they could get infected with an additional strand or a drug-resistant strand of HIV. And this can cause superinfection because the medication that they're currently using may not work as well against their current virus or the new virus. So taking all this information into consideration, the national statistics for HIV, Louisiana-specific statistics, and the background of AUD in our population, we developed the WELL program. We developed the WELL program using the Assessment, Decision, Administration, Production, Topical Experts, Integration, Training, Testing, Model of Intervention Adaptation, or ADAPT-ITT for short. Our intervention was adapted from an original evidence-based intervention called the Holistic Health Recovery Program. This intervention was made by one of our study members, actually. So the Holistic Health Recovery Program, or HHRP, was an intervention designed to target sex and drug-related risk-taking in HIV-positive intravenous drug users. So from this intervention to ours, we did a qualitative assessment where we collected information from clinicians, social workers, mental health educators, and also educational providers and HIV-positive patients to identify behavioral needs of the people living with HIV and we determined to adapt 4 of those models from the HHRP into our intervention. And all of this data is published, like our qualitative assessment and the development for our WELL study, along with our pilot study, has been published. So our interventions, we had 5 session topics. The first one was healthcare participation, where we taught our participants to be more active in their healthcare. We also taught them about the consequences of ART non-adherence, so what happens when you don't take your medicine. And then we taught them strategies for overcoming those barriers. Our second session was to reduce the harm of alcohol and drug use. Here we taught them how to identify those problematic drinking behaviors and then the standard drinking amounts. We also taught them about the harms of alcohol and drug use can have on their HIV status, and then some techniques to mitigate those harms. The third session was harm reduction using latex. Here we taught them the harms of unsafe sexual practices and harm reduction techniques using latex condoms. Fourth one was really important because we can't teach our participants these new behaviors and new changes without negotiating harm with their partners so they can take them home and use them. So we taught them about condom negotiation and communication skills using didactic, visual, and role play demonstrations. Our fifth and final session was healthy lifestyle choices. Here we taught them good coping skills and how to manage their stress in a healthy way, and then also nutritional guidelines and food hygiene. So for my analysis of the WELL program, I hypothesized that participation in the WELL program increases self-efficacy, readiness to change, and a greater reduction in drinking compared to the treatment as usual group. Our methods included that we recruited our participants from the University Medical Center in New Orleans, specifically the HIV outpatient clinic. Our inclusion criteria was, of course, you had to be HIV positive, 18 years or older, and for men, an alcohol use of 4 or more drinks in a week. For women, 3 or more drinks in a week. And for both sexes, a consumption of 6 or more drinks on one occasion. Our data collection included a baseline, and then we had randomization. Our total study size, total sample size was 202, of which 100 got randomized to our WELL study arm, and 102 got randomized to our control group. Then we had our intervention, which included the sessions that I just mentioned in the previous slide, of which we did those 5 sessions on a weekly basis. And our goal was to keep our intervention classes to 5 participants, to keep it intimate. Our follow-up period included data collection at 3 months, 6 months, and 12 months. So these are a list of questionnaires I would ask the participants during the baseline and the follow-up period. I'm not going to go over every single one because it's a lot. But for my analysis, I analyzed the general self-efficacy scale, Socrates version 8, and the timeline followed by counter. The general self-efficacy scale was used to assess participants' confidence in their own ability to change behaviors. Socrates version 8 was used to assess the participants' readiness to change behaviors. And then our 30-day timeline followed back, we administered that questionnaire to ask the participants what alcoholic beverages they had in those prior 30 days. We had to remind them that, yes, wine counts as liquor. Beer, malt liquor, cocktails. New Orleans, we have daiquiris, hand grenades, everything you can get on Bourbon Street. So we had to, probe them and ask them what they had to drink the past 30 days. And then it was the interviewer's job to standardize that to the standard drinking amounts. And all of our data was analyzed using the general estimating equations to analyze the effects of the intervention on behaviors. So my population characteristics, as you can see, we had a very well balance between our treatment groups. Our population was majority male, and it was majority African American. Our mean age was about 48 years old. For our educational levels, majority of our participants had a 12th grade level education, and then the next highest category was less than 12th grade. For employment, our participants were allowed to choose multiple options. As you can see, most of our participants were on or applying for those disability benefits. And then our next highest category was unemployed or other. Here I wanted to look at our population based on the diagnosis. What I found was the control group had a range of having HIV, living with HIV from 2 to 42 years. And our WELL group had a range of living with HIV from 2 to 35 years. So the first result I wanted to discuss is general self-efficacy. This is the confidence in one's ability to change behaviors. Here I thought it would be good to stratify on diagnosis length, because those people who may have been recently diagnosed with HIV versus those people who have been living with HIV longer could be affected by, their length of diagnosis could affect their confidence and their ability to change behaviors. So I found that those participants with an HIV diagnosis of less than 15 years did have a significant change in their self-efficacy from baseline to post-intervention. Next, I assessed their readiness to change, and I did not find any significant difference in either treatment group. And third, I looked at the alcoholic drinks in the past 30 days, and we did find that those people who participated in our well-studied intervention did have a significant decrease compared to the treatment as usual group in the reported alcoholic drinks in the past 30 days. So in discussion, we believe that it's important to focus more on educating our participants on the harms of alcohol use, the consequences of poor medication adherence, and dangers of risky sexual behaviors. As I mentioned in my results, the well participants with a diagnosis of less than 15 years had a significant change in self-efficacy at 3 months. Alcohol use had a statistically significant decrease among our well participants compared to the treatment as usual group. And some additional observations from our whole study, and not just my analysis, was that a proportion of low ART adherence decreased among the well participants. The well participants also lowered their reported sexual risk-taking behaviors at follow-up compared to baseline. And then I listed the limitations because those are common for intervention and self-reporting studies, that recall bias and interview bias could occur. And one of the big strengths of just the overall experience of the well study is that it was an open space for participants to vent about the stigma related to their HIV status and just any other topics which they may not get at home. So in conclusion, it is important to build on existing evidence-based interventions in order to optimally address population-specific behaviors such as alcohol use disorders among those people living with HIV or AIDS. Our findings provide evidence that participation in the WELL program does decrease risky alcohol use, but the sustainability of these behaviors do require further investigation over time, and we do have assessments in place to look at our behaviors, to include the 6 and 12-month post-intervention data, as well as qualitative assessments, so we can get more feedback on strategies to improve our intervention. These are my acknowledgements. I would like to acknowledge Dr. Patricia Molina, who is the director of the Alcohol and Drug Abuse Center of Excellence, Dr. Chiquita Ferguson, who is my research mentor, our biostatisticians, and my colleague, Alice Ye. And this project is supported by the LSU Health Sciences Center, Comprehensive Alcohol Center, the Alcohol and Drug Abuse Center of Excellence, and LSU Health Sciences Center, Departments of Physiology and Epidemiology. And these are my references, and thank you for your attention.